three steps together. Step one is there is a normal endocrine function, then there is an abnormal endocrine function, and there is an abnormality in the human being, right? So we talk about the physiology. From physiology we understand the pathology. From pathology we convert to the clinical practice. So here this lecture is about connecting these three things. So you all know that pancreas is secreting main hormone, insulin, glucagon, right? And insulin's main job is
taking the glucose inside the cell, uptake.
So we call it, this insulin glucagon actually are trying to maintain glucose in certain level. If they are not working well, it will become hyperglycemia or glucose problems mainly, right? So when this glucose is not controlled in the human blood, how patients feel? So what are the complaints called as symptoms that patient can have if there is too high, too low amount of hormone in the body, or what else might be a problem? So we have to understand how patient presents and why they present like that. So that is what the main idea behind this session. So I am assuming that you already know that what is islets of Langerhans and what are different cells in the islets of Langerhans. That is number one, right? And I am assuming that you know which hormone comes from which cell, right? And then what is the main job of this hormone in the body. So that is what you already know. Then we need to understand from this order to a disorder. So from disorder we need to understand that any gland problem basically presents by two mechanisms. What are those two mechanisms? And then we focus for not any gland problem but the pancreas problem, right, which is one special gland. Then we talk about the hyperfunction, then we talk about the deficient function, so high and low function of the gland. And then based on that we try to see when patient presents how we pick the problem and how we try to reverse it back. So I will say that we have three parts: order, disorder, reorder, right? So these are three main ideas that we are going to focus on. So let's focus on the order part. You already know that, so let us check that how good you are. So this diagram shows numbers. You have to tell me the names of the cells or the name of the structure. So what is number one? Capillary. Okay. Number two?
Epithelial cell. Epithelial cell.
So you have not seen, you have not the histology or this?
No.
So how come they are asking me to teach you clinical thing without teaching
We
that?
didn't take histology and anatomy of the
We
pancreas.
just took the investigation and you know,
And
So in
physiology.
anatomy, you have
Physiology,
not-
we take physiology.
Not in this
لا،
course.
ما.
In anatomy, you have not done histology, you have not done
No,
that.
anatomy and histology there is.
For pancreas, we did not do it. For other organs, yes.
Okay. So you know what is islets of Langerhans,
Yes.
right?
It
So
is
where
this-
you read that?
The cell.
And human body one.
So human body wonders. Okay. So you know that, right?
Yes.
So pancreas has two parts, right? One part secrete chemical and it goes into the intestine, right? We call it exocrine pancreas. And one is secrete directly in the blood. We call it
Endocrine.
endocrine, right? The word jazeera is island.
Yes.
The small jazeera is islet, right? So it's like a big sea in which there are small jazeera. So these small jazeeras are islets. This is one islet, right? So in that island, there are different cells, and these cells will put chemical into the blood. So there is a blood. So this red color thing, three red color things are blood capillaries, right? And they are surrounded by, you see, three different types of cell, right?
Yes.
One is at the end of the cell, the end of the circle. One is little bit bluish or yellowish, right? But I am saying there are two. It's actually the frame is bad. One is yellow, one is green. So you see, yellow color nucleus is white, right? So I have made it like that, and green color nucleus is black, and then there are gray color cells, right? So these are 3 cells. So we will know that some of them is alpha cell, some of them is beta cell, some of them is delta cell, right? Alpha, beta, delta. These are 3 names, right? So we'll come back to it. Now, this is the schematic diagram. So alpha cells secrete glucagon, right? So how I remember that alpha cells secrete glucagon? You see alpha, right? The shape of alpha is very much similar to A in English, right?
Okay.
So alpha is like A. Insulin don't have A in it. INSULIN, right? But glucagon has A in it. So alpha is like A, glucagon, right? That's a simple formula. So we try to remember that alpha cells secrete glucagon, and glucagon is doing catabolism, right? While beta cell is producing insulin and insulin doing anabolism. While delta cell is producing somatostatin, and somatostatin is actually controlling secretion of hormones of these 2 cells, right? So that is the 3 main things. Now, so the formula so that's the background we need. Now we go to the disorder, right? So here I'm talking about every gland: thyroid, pituitary, suprarenal, pancreatic, every gland. Disorder of a gland means either the hormone it is producing is a problem, or it is taking the space, it's multiplying and getting bigger. So we say gland disorders are either problems of the hormone or problems of the mass, right? It can be both. Yani a bigger gland is also producing too much hormone. That is also possible, right? It is also possible that the gland is not bigger, it's producing too much hormone. It is also possible that a gland is getting bigger but is not secreting any hormone, right? So any combination is possible. Faqat deranged hormone is also possible. Faqat mass effect is also possible, and a combination is also possible, right? So that is what it is. Deranged means there are 2 possibilities, right? So we said this is the lowest limit, this is the highest limit. This is the range of hormone. Folk becomes too much. Tahat becomes too little, right? So we divide deranged into hyper and hyper, right? Similarly, mass effect can be, it is getting too much bigger and it's pressing the remaining gland, so not allowing the remaining gland to function. Or it is very small, but it is like a cancer, right? So we say mass effect like pressing the surrounding structure, right? Or having a small nodule which is either producing too much hormone or it is having a cancer, right? So okay, compression means it is pressing the surrounding structure, right? For example, thyroid is on trachea. If it is multiplying a lot, it will press the thyroid. That's a compression, right? So there you need the anatomy. If I am talking about pancreas, what is around the pancreas, right? That is very important. So you know and I know that the common bile duct is actually passing from the pancreas. So if there is a tumor of the pancreas, it will press the bile duct, right? And bile duct takes what in it? Bile, right? The chemical, the secretion of bile. Bile contains bilirubin, salts. So if this is pressed a lot, bilirubin will not go out.
Obstructive jaundice?
So obstructive jaundice will occur, right? Okay. So one of the presentation of the pancreatic compression effect is obstructive jaundice, right? So now you see that is the connection that we need. Okay, so coming back to now this again the color is red. So there you see alpha is like gluca. So A, that's how you remember. This is many students actually ask me that in the exam we usually forget which one. We know it's alpha and beta, but whether it's one glucagon or what, that mix. So now the format you remember is alpha is like A, right? Okay. So it is glucagon, right? So that's very simple thing. Okay. So the names are, red one is blood capillary. The one which is at the border of the island is alpha cell. The one which is towards the center as well as the border is beta cell, and one which is not at the end is the delta cell. Right? So that is how. So alpha cells are on the outside, the mazafat, and beta cells are wast madina, mainly. Right? So that is how you remember. Right? So that is the normal structure. Now, if there is a hyperfunction, so I can say increase glucagon is called as glucagonoma. If it is beta cell, increase insulin becomes insulinoma. If delta cell increase becomes insulinoma. Right? So that is how it
بس
is.
كلمة هايبر صغيرة.
You don't have the lecture now?
No, we have it.
No, we have.
Right?
Okay. I have PowerPoint.
We have.
Good.
Yes.
Okay. Now, so this is how the name is. So hyper. So now we say the pancreatic cell tumor or islet cell tumor, they are not very common tumors, right? Common tumor are lungs tumor, breast tumor, like these. So islet tumors are not very common tumor, but if it is, because the pancreas anatomically is in a big space, so it gets bigger and bigger and there are no symptoms, right? Who actually made iPhone first time?
Who made iPhone first
Who made
time?
iPhone first time?
مين اللي صنع
And out of pancreas now. Who made iPad? Who made iPhone? Who was the founder of Apple?
I don't know.
Steve Jobs. Steve Jobs. He is alive or dead? How he died?
Pancreatic cancer.
Okay.
So that's what happened, right? Why pancreatic cancer? He had pancreatic cancer, but pancreas is the biggest space, so there was no symptoms, right? When he felt some problem, so he started losing weight. So you see, when he came for iPhone 1, he was wearing a black t-shirt and a jeans pant, right? Then iPhone 2, then iPhone 3. So if you see on Google, you will see his weight was changing, right? So he was very heavy on iPhone 1.
Yes.
The more money came in, his weight was lost, right? And he never knew that he is losing weight because of the pancreatic cancer, right? So that is what it happened. So the story of Steve Jobs is because of that thing. Most are benign cancer and are until they start secreting hormone. So what happened that he was working in his office and suddenly he lost consciousness. When he lost consciousness, his blood sugar was tested and it was very low. So when his blood sugar was very low, he was injected sugar. But normally, if you are not taking insulin injection for diabetes, you do not get low sugar. So there they thought that he might have high insulin secreted from the cancer. So,
Can you repeat that point before?
so he was working in an office and he had a loss of consciousness. So whenever, if you bring a patient who has lost consciousness in the emergency, the first thing we do is we check the sugar level.
Yeah.
So his sugar level was very low. If it is low, you inject extra sugar, right? When it was injected, he wake up. Now, sugar low is usually because of high insulin.
Yeah.
Now, high insulin usually is because a diabetic patient is injecting insulin as a medicine. Steve Jobs never had diabetes.
So he have
So
cancer.
he had high insulin. That is what's causing sugar low. So, and he was not diabetic. So he thought insulin is produced from the cancer. Then they did an MRI scan. And they see the pancreas has large enlargement, a mass, right? So it was too late. So that's what the issue is, that because anatomically pancreas is very separate, right? So it gets bigger and bigger and does not cause any compression until it is too late, right? So that's what the asymptomatic until secrete hormone. 10% are malignant, yani 90% are not malignant. He was unlucky, he had malignant cancer, right? So we say if it is beta cell only, we say insulinoma, and that causes attack of hypoglycemia, loss of consciousness, right? Gastrinoma produces peptic ulcer disease is a gastric tumor which is going to the stomach and saying produce more pepsin, right? So that more hydrochloric acid will cause us ulcer, right? Glucagon, somatostat also, because these two will stop insulin from functioning. So insulin is not working, person will get diabetes, right? This is called as secondary diabetes. It's not because the problem is in insulin. It's because something is blocking insulin function, right? So then it's called as secondary diabetes, right? Then there are other hormones as well. So that is what the issue is. Coming back to this, we are talking about hyper. What other problem can occur?
Hyper.
So we talk about now the hypo part. This is another thing. Gland problems usually are one gland problem alone. But if there is a cancer in one gland, there is a high chance that there is a cancer in other gland as well. Gland functions is what? Do synthesis of hormone and secrete, right? So their gene are controlled by a particular gene called as proto-oncogene and tumor suppressor gene. So if there is a problem in proto-oncogene and tumor suppressor gene, then all the body cells which are controlled by these genes will get cancer. So the simple answer is, if there is a one gland cancer, you think of another gland as well, right? So it's the word in English called as poly meaning many. So polyglandular disorder. So if I see insulinoma, I have to check for other glands as well, right? If I see glucagonoma, I see for other glands as well. Combination of gland disorders are like this. So you see, it's called as multiple, many, endocrine, you know endocrine, neoplasia, cancer, right? So it's a combination of glandular cancer. So men, multiple endocrine neoplasia, type 1 has pituitary tumor, pancreatic endocrine tumor, parathyroid adenoma. These three combined is men 1, right? Men 2 has two categories, 2A, 2B. So 2B, 2A has parathyroid tumor, medullary thyroid cancer, and pheochromocytoma, while men 2B is like that. So I used to make this kind of diagram. So here you see this is men 1, pituitary, pancreas, parathyroid. This is men 2A, parathyroid, thyroid, and pheochromocytoma. This is men 2B, thyroid, pheochromocytoma, mucosal cell neuroma, right? So that is how it is. This is the formula is written over here. Men 1 is 3 P's, men 2A is 2 P's, men 2B is 1 P.
Doctor, I didn't understand the picture.
Okay. These are, you know what is pituitary, what is
Yes.
pancreas?
Yeah.
These are names of different glands, right? So, pituitary gland, pancreatic gland, parathyroid gland. If the tumor are in these three glands, the combination is called as men 1, right? If parathyroid gland, thyroid gland, and pheochromocytoma is the problem, then this combination is called as
Men too.
men 2A. If thyroid, pheochromocytoma, and mucosal neuroma, these glands are combined, then it is called as
Men to be.
clear. So here you see P, P, P. So there are 3 P's in men 1. There are 2 P's and 1 T. There are 2 P's in men 2. There is only 1 P in
Minus 3.
right? So in the exam, they will either ask you, is it men 1, 2A, 2B? So I will simply say how many P's are there. If all 3 P are there,
Men 1.
easy.
Yes.
If 2 P are there,
With 1 T. Men
T or Mafi T.
Men
2 P is 2A. 1 P is
to be.
Khalas. Right? That's how it is. Okay.
Okay.
So what we are saying that there is a tumor. There are 2 possibilities. Only fakat one type of tumor or
Multiple.
multiple tumor, right? So that's one possibility. Now we talk about hypofunction, right? So beta cell is producing too much insulin, right? And that too much insulin will cause,
Diabetes.
right? So here we are talking about, there are two possibilities. Either the insulin is not produced or insulin is not working. So there are two possibilities. Insulin is not produced or insulin is not working, right? So if I have a mufta, right? So, and there is a lock. If my mufta is faulty, this will not work on the lock.
Insulin resistance.
Insulin resistance. Or if I don't have any mufta, that means, so you say absolute, yani complete deficiency, and relative, it is there but it's not working, right? There are two kind of possibilities of diabetes. So what happens in diabetes? This is the key diagram that you have to, the group which was working with me in PBL, right? PBL and results like this diagram is called as concept map, right? So you make like these arrow, and that explain everything. So here it's hyperglycemia. If too much glucose is there, it will be filtered from glomerulus. So glomerulus releases glucose and then reabsorbs. If up to 180 milligram of glucose, everything will be reabsorbed. More than 180, now kidney is working maximum. I can take 180 per minute. But if you are putting 200, 20 will go into the urine, right? So more than 180 sugar, now kidney will start losing glucose. And glucose is moving, so it will take water with it. So if there is too much glucose in the blood, it will go into the kidney and will make more urine. More urine means polyuria. So one feature is polyuria, right? When you are losing too much glucose in urine, glucose is used for energy. So I am eating, but I am losing. So I have less glucose, that means I have tiredness. My sugar is not available. If I am losing glucose, I am losing urine, glucose plus water. So when I am losing too much water, I will feel too much thirst. So that's what they are talking about. Too much glucose means high plasma osmolality, right? So that high plasma osmolality will cause too much urine formation, too much feeling of thirst. So this will cause polydipsia and this will cause hypovolemia. So patient will have tiredness. So this is what the first thing. The control will not happen.
Doctor, sorry, but I don't understand why there is too much urine.
Okay, urine has water, right? Water is because urine is containing too much glucose. With them, glucose zyada. So that glucose will filter from glomerulus and become in the kidney, right? But glucose, when glucose will go, glucose will pull water with it, right? So there too much water, yani polyuria, right? That's it is. So that's number one. So now we have glucose, but we cannot use glucose for energy. So when we cannot use glucose for energy, what we will use? So fat, right? So now your body is not receiving glucose because insulin is not opening the gate for it. But you have stored fat. So once body is not using glucose, then body will ask for fat to come and will do breaking the fat. So second thing is fat catabolism. So when fat is broken down, it makes fatty acids, right? So one of the fatty acid is like this, and fatty acid is broken down to make something which is called as ketone bodies, right? So now glucose is not used, fat is used a lot. So too much end result of fat metabolism is ketones. This ketones will be more and it will come out of my body. So it comes from the lungs, in the exhalate power. It comes in the urine. All our aturat, perfumes, primarily contains ketone chemicals. That means it has a smell of like acetone, right?
Oh, alcohol.
So that patient, when he is breathing, there is a fruity smell coming from it, right? So that's called as ketosis. Ketone are acids. So there will be too much acid. Urine becomes acidic. So this is second thing. I cannot use glucose for energy, right? So I am using fat. Fat is not too much. What else I will use for energy? Proteins, right? So now, this primarily is glucose is not available. So I will go kill fat, go kill amino acid.
Okay.
When I am degrading amino acid, muscles is all protein. So you lose the muscle. So you lose weight, right? Your antibodies, immunoglobulin are proteins. So if you are breaking proteins, then your immunity will become weak.
Doctor, why I will break the proteins?
Why?
Yes.
Why said I not answer the question.
Why?
Why?
we break the protein?
Okay. What is the job of glucose in the body? Break down, give energy.
Yeah.
Right? Energy maafi module because I cannot break glucose in diabetes.
Yes. We
So
will break the fat.
but I need to break something.
The fat.
So if I cannot break glucose, what other two things I can break? Fat and
Protein.
protein, right? So I am breaking protein because you see in chemistry, right, in school, we read that there is a bond, carbon-carbon bond, right? You break those bond and energy is released, right? So glucose has many carbon bonds. When you break it, it gives too much energy. But protein has carbon-nitrogen bond, right? Not much carbon-carbon bond. So protein is not good for energy. But now if you don't have, then you have to get whatever. So energy from glucose is not there, you break fat, you break protein, right? That's what is happening. So this is why when you are breaking too much protein, so what will happen? That this together with yani 1 and 2, after these two things, it will cause
This way.
and body will demand more energy, right? Because now store is going out. So people will eat a lot and yet they will lose, right? So that is what the reason is. Insulin problem can be because islet cell, beta cell is damaged by something, right? If beta cell is damaged, now insulin will not be produced, right? That leads to absolute deficiency of insulin. This is called as type 1. Insulin is produced, but insulin cannot work well. That is type 2 diabetes, right? It is not a problem of insulin. Yani some other hormone has increased a lot which is not allowing insulin to function. Then it is secondary diabetes. These are primary. Like somatostatin. You had one lecture, I don't know your other class, is suprarenal gland problems.
Yeah.
Right? So,
Aldosterone.
right, aldosterone. So if corticosteroid, Cushing syndrome, if steroids are too much, right, these steroid causes diabetes. Why? Because steroid hormone blocks the hormone insulin function. So it becomes, now it is not type 1, type 2, it's called as secondary. Why secondary? Because it is not because of the insulin. Something else is blocking the insulin, right? So secondary diabetes.
Now, we talked, Doctor, type 2, it's insulin resistance.
Type 2 is insulin, type 1 and type 2 is a problem of insulin.
Type 1 and type 2.
Are problem of insulin. Type 1 insulin maafi maujood. Type 2 insulin maujood maafi sugar. Secondary insulin is okay. Something else is stopping insulin to function. Right? Clear now?
So primary, it has type 1, type 2.
Type 2. Right? Now we talk about the third thing. In pregnancy, there is a placenta, right? Embryological concept. From placenta, there is a hormone called as human placental lactogen, HPL. That is against insulin, right? So some pregnant women release this high amount and then insulin function is not there. But once the placenta is out, delivery, baby born, placenta is now that human placental lactogen is maafi maujood. So diabetes becomes normal. So this is diabetes of pregnancy.
Gestational.
So gestational diabetes. So here you are seeing there are 4 types of diabetes: type 1, type 2, gestational, and other specific types. I am taking some medication, like one of them is methotrexate, is a medication. That actually damages my beta cell, right?
Methotrexate for tension.
Methotrexate is for many reasons. One is for cancer, one is for autoimmune conditions. So if I am taking methotrexate and methotrexate has damaged my beta cell, right? So it is damage of beta cell. Now I will have diabetes. It is not type 1,
It's secondary.
it's secondary, right? So that's called as specific type of diabetes, right? So these are 4 main types of diabetes. So now each of these diabetes have one main common thing: hyperglycemia. So all of them will have polydipsia, polyuria, polyphagia, weight loss, all of it like that, right? That's the beginning. Once you have high glucose, now that is not there in the slide because it's a little bit high tech. So I will give you a little bit of idea of it. It's not coming in the exam anyway. Now, if I put like cells of the body, all the cells are here, right? Eye cell, muscle cell, intestine cell, nerve cell, glomerulus cell. So insulin is working on some cell for glucose, right? Insulin is not required by many cells, like neuron cell do not need any insulin. It will take glucose directly because glucose has 4 types of receptors: GLUT1, GLUT2, GLUT3, GLUT4, right? So only GLUT4 receptor is stimulated by insulin. So GLUT2 receptor has nothing to do with insulin. All those cells which can produce GLUT2 receptors, they with or without insulin, they have nothing issue. Now think about it like a sail, like the flood, right? So this is the water motion, right? In this water motion, if I put a block here, what will happen? Water will change the direction. Now, if I have one tarikhina, and sail is coming in, this is blocked. So what will happen? They will go to open sides. Now, use that idea. We have many cells. Some cells, no need of insulin. High amount of sugar can take it. Some cells need insulin for it, right? So now, if insulin is not working, sugar is high. Where sugar will go? Those who do not need. So these 4 now remember. Retina cell, right? Retina cell. Retina itself is a cell, right? So rods and cones cells, retina cells, blood vessel cells, right? Glomerular cell, neuron cell. 4.
That's why you
Red
have
blood
this
cell.
sensation.
Red blood cell. We'll come back to you, right? Now you're connecting it, right? So that is what the connection is. That's why I said make arrows. So if I have too high sugar for a very long time, what 4 cells will damage more?
Neurons, retina,
Glomerular.
blood vessels.
So a patient with diabetes has retinopathy, right? Nephropathy, neuropathy, heart problems, right? So if a patient comes with diabetes, what I am worried? High sugar and these problems, right? So once I have confirmed diabetes, I will check his retina, whether the retina blood vessels are normal or any change. So there are grades of changes. We are not going to talk about it now, right? Similarly, kidney, there are level of daraja of, this is what they are not talking about, daraja. Nahin, marahil. You said marahil. So there are marahil of damages, right? Early damage, late damage, like that. So I am interested in, this is sugar, this is diabetes. What is the marhala or marahil? What do you say? Marahil,
Marhala
right?
is single.
Marhala is single, right? What marhala?
Stage.
Stage of complication the patient is in, right? That I need. Because if it's a retina problem, I need to do something, otherwise he'll get blind. If there is a kidney problem, I have to do something, otherwise he'll have kidney failure, right? So that is why we check the sensations, the nerve issue. That is why you see the feet, the blood vessels are okay, otherwise there will be an ulcer, right? So these are complications. Now, coming back to our lecture. 3 types of patient come with problem. One, my father has diabetes, check me. So he has no symptom, but he is worried. That is one part, right? One group of patient. Another group of patient comes with the early symptoms, polydipsia, polyuria, tiredness, right? And another group of patient come with complication. Doctor, yani bin nazarat, mashakil, right? I have sore throat again. Why? I have little cut and it keeps on bleeding. I am not healing well. So his proteins are less, right? So you think of, normally we all get flu, meaning 1 year we got 3-4 times. What if every month a person is getting flu?
No immunity because.
So there's a problem of immunity, right? Now, antibody is protein. If his insulin is not working, he will lose antibodies. So he is at risk of repeated infection, right? A woman comes in and said, I have urinary tract infection, right? And you treated it, after 1 month, again urinary tract infection. So there is something wrong with the immunity. So the 3 types of possibilities are no symptoms, but worried about the family, right? Early symptoms, polydipsia, polyuria, tiredness, complications. So I think from that perspective, this is one category. Now, kidney failure can be because of diabetes, can be because of hypertension, right? High blood pressure. So if somebody comes with high blood pressure, I am worried about blood pressure and kidney failure. So I will think if this patient has hypertension, his kidney is at risk. His kidney can also be at risk because of diabetes. So any person who has cholesterol problem, blood pressure problem, I need to check for diabetes as well, right? These all are called as khatar, risk factors, right? So if one risk factor is there, you look for another, right? Clear? But this is just the understanding on top of it, right? For this course, we are interested in why a patient has polyuria, why a patient has increased thirst, right? Classic things. We are not interested in retina. So now we go to this case, the last part. So how to do a reorder, right? 30-year-old woman was seen with the acute onset of lightheadedness, chills and shaking. Glucose level detected by glucometer 32, yani below 60 is very low. So this sugar is very low, right? She was eaten candy and fruit juice and her symptoms resolved. Yani when sugar came in, she got better. The same thing happened to Steve Jobs, right? The patient reported that she had experienced similar symptoms, but of lesser severity for approximately 1 year, so it's going on, right? As per patient's information, most episodes were in the early morning. Yani when she had taken the food and the food has been for a very long time, she has not eaten. So it's the end of the day. Associated with prolonged fasting or overexertion. She also reported a recent 15 kg weight gain. Weight gain, remember that, right? Sugar is going low, weight is going up, right? She denied having seizure and diabetes, but noticed increased appetite in the past year. She had no family history of diabetes, thyroid. Why they are talking about thyroid, pituitary?
Because thyroid.
Good, right? So now, if I am thinking of one gland problem, I will also think of other gland, right? 3P, 2P, 1P, and some T, right? Blood sample taken at the time of hypoglycemia showed low plasma glucose, 36, that's there, right? And high insulin. So insulin level normally is from 1.7 to 31. Her insulin is 94, right? 10 times higher, right? What is the importance of this elevated C-peptide?
PP or hormones will indicate how much hormone of insulin will be produced.
Okay. Amino acid, amino acid, amino acid, amino acid, amino acid. So insulin is a bunch of amino acids connected together. So you can convert amino acid into a C shape of an English, right? So that C upper part and lower part is connected by sulfide link. This corner of the C is cut and removed. This becomes insulin. This cut C part is C peptide. So if my body is producing insulin inside, for each molecule of insulin, there will be one C peptide. But if I am injecting insulin from outside,
No
I will
C
have
peptide?
high insulin but
No C
No,
peptide?
low C peptide. So I am interested in, now we go back to, right? So same question is asked like a 30-year-old nurse came in the emergency with low sugar, right? She had multiple injection marks. How would you confirm that she is actually injecting too much insulin and it is not insulinoma? So if it is insulinoma, insulin is produced dakhil jism,
I will
For-
see C-peptide.
right? So I'll get it very easily. So that is one of the questions they ask a lot, right? How do we differentiate between insulin produced inside the body and it is more
C-peptide.
versus insulin produced outside the body and it is more? C-peptide is it is, right? So that is one. So that is why it's saying C-peptide. So her C-peptide is also high. Normally C-peptide is almost 4 nanogram. It's 10. That means this high insulin is
From inside.
from inside, right? So,
So,
are you right?
again, what is the difference between the normal insulin and the drug?
Normal insulin and no, sorry, again, normal insulin and
I was asked about the difference between the insulin normal or injection.
okay. If you think of like what you call this in Arabic, where we actually recite Subhanallah, that thing.
What?
We English we call it rosary.
What?
What's it? Yes. So you see that asbah, right? So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Amino acids?
So these are amino acids, right? Now out of these amino acids, so insulin is created like 1 amino acid, 2 amino acid, 3, 4, 5, 6, 7, 8, there are 100 and something amino acids. So I take this whole amino acid and turn it like this, right? So from your side, think like English C, right? This is English C, right? From this English C, I cut this part, this part. So this become top level, this become lower level, right? So now these are two different things. This is C peptide, this is another molecule, and this is insulin.
Where is the end? Where
Right.
قطعناها عن C.
So now when we make insulin dakhil jism, for each insulin molecule there is one
C peptide.
C peptide, right? But if I am injecting insulin from outside, that does not contain C peptide. So if in my body insulin is high, it can be because my pancreas producing a lot or I am injecting from outside. How can I differentiate? So C peptide will be high if it is from inside because insulin C peptide savas.
Doctor, it's something good when C peptide is higher or only
If C peptide is higher, what else will be higher?
glucose?
C peptide is produced
insulin?
with insulin. So high insulin is mafi كويس, right?
طب ليش نعمل انجكشن؟
يعني من برا ولا من الجسم أسوأ؟
I don't have a mark.
عملتي من برا
I will draw it later, right? So understand very well.
مشان تفرق انه هذا اللي عنده زيادة.
So now,
إذا ما صار في بالسي بتاعي بصير أسوأ ولا؟
so we go to the next case, then I will show you the diagram. It's much easier. Now this is case 2. This is the last case, right? So the previous case was that of high insulin produced from the body, and what I will do an MRI scan to see whether pancreas has enlargement or faqat insulin. Two problems were hormone only, mass as well, right? So if it is hormone only, then it's okay. But if it is mass as well, then it's tumor. So I have to deal with the tumor, right? So that's right. Case 2, 50-year-old female presented. Now you have seen that in both cases I am using female. Glandular problems usually are more in female, right? 50-year-old female presented with 2-year history of hiccup, pruritus, and ulcerating skin rash. So it's a skin problem, right? Which initially appeared at the waist here and slowly progress to the entire body within 3 months. The patient also complains of blur vision, cannot see well, and weight loss. Right? The patient was initially diagnosed with a skin condition, pancreas, and treated with prednisolone. This is steroid. Right? Cortisol. You remember cortisol? Glucocorticoid. Right? So it's a synthetic cortisol. Without relief of skin rash prior to admission to our clinic. Physical examination reveals the skin lesions were erythema, red, flat lesion, right? And there are crusting. Laboratory tests include elevated blood glucose. So now you are linking that something is blocking insulin, and that is second prednisone, right? Associated anemia, hypoproteinemia. Following admission, the patient underwent abdominal CT scan, and it turned out to be there is a pancreatic body mass with low density. Question is, why there is a hiccup? What is the link between pancreatic tumor and hiccup? The pruritus. You got hiccup, right? Reaching. So why?
Jaundice?
How? You're right, very close now.
There's muscle.
What is in the bile?
Salt.
The bile salt, right? If the bile duct is blocked, compressed, what will increase in the body? Bile salts. Bile salts will cause hiccup.
Okay.
Right? So that's what it is. So this is the second place. Given her history of skin rash because too much hiccup, diabetes and pancreatic mass, the patient's blood glucagon concentration was measured and her fasting glucagon level was noted to be elevated. So now this is a case of glucagonoma, right? Insulinoma, glucagonoma and diabetes. So that makes our 3 clinical presentations. Now I will show you that C-peptide issue, right? Then we are done.
Doctor, may I ask a question?
Yes, go ahead.
Now, primary diabetes, it's type 1, type 2.
Right.
It has 2 types.
Two.
Secondary is alone.
Secondary is alone and gestational is alone.
Okay.
Doctor, why the bile salt will increase?
Excellent. Why bile salt will increase the following? Let me finish this part first. Then I will come back to you. Yes, here it is.
Okay.
Now you see this diagram? C-peptide issue. So amino acid, all amines, right? So I can make it like one line.
Yeah.
So you turn it like that, right? Now, normally this all is produced, then you cut from this part and you cut from this part.
This is
So
the
if I
insulin
cut
and
this part, this and this is insulin and this is
C-peptide.
C-peptide, right?
Okay.
So normally insulin is produced like that, but when you cut, it looks like this,
Beta and alpha chain.
and then alpha and beta chain. Clear?
Yes.
Why this is very important? One is C-peptide,
To know
right?
if it's injected or it's from our body.
So that is one, right? Another very important concept
Sequence
here
of
is
amino acid.
sequence of amino acid. There are now, you see, alpha chain and beta chain, right? So we have insulin. Diabetes, we treat insulin, right? Initially, insulin was produced from the pancreas of animals. Then we have insulin produced from the laboratory. Now we have insulin which is not exactly like this, right? So insulin, amino acid sequence, chemically we change the amino acid sequence and make something similar to insulin. So that's called as analog insulin. Analog yani soya tagayyur bil insulin, right? All these insulins which are soya tagayyur is called as analog insulin. They are not exactly insulin, right? They work better than the insulin, right? So if I give insulin, I have to give large amount of insulin to the patient. But if I change insulin a little bit and give, then I have to give less amount.
Because
Right.
higher effect.
Because of higher effect, right? For example, if I write down here Yes. So now you see there are very specific sequence here. These are all amino acids. So somewhere here you will see proline and lysine, right? So these are the numbers 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So here it is 27 and 28. If I take 27 and 28 and I change the order, 28 will become 27, 27 will become 28, right? So normally it was proline lysine. We change it to lean. So that insulin is called Lispro insulin, right? Lispro lysine proline. Normally it was proline lysine, right? So that becomes Lispro insulin, right? There is one more chemical we attach here, right? We attach here a large molecule. It makes heavy molecule. So now you put insulin. Insulin is heavy molecule. It will slowly absorb. It will not absorb very quickly. So that will absorb in 24 hours. So I put only one injection, 1 day is enough. It's called as long-acting insulin, right? So if I change fakat the beta chain, only one chain, the beta chain, that will make insulin more effective and quick in action. So it's called as rapid acting
لا
insulin.
هذا عادي بس الانالوج اللي عم بقول لك
Can you put
بالسبب
insulin will work very fast, rapid acting. But if I change in both alpha and beta, it will become bigger and it will become long acting insulin, right? So if I want to treat diabetes, I will give low dose of long acting insulin which will work for whole day. And qabal ghada, qabal asha, I will have short acting insulin, right? Got it?
Yes.
So all depends on this C-peptide concept. Clear now?
Yes.
So that is the lecture. So what can come in the exam? Insulinoma, glucagonoma, right? So three things are which cell, which hormone, what effects of the hormone, right? So insulin, which cell?
Beta.
Beta, right?
Yes.
Alpha is glucagon, right? That's easy. Use these techniques, make your life easy,
Okay.
right? Have a nice day.
Thank you.